Welcome to the Advancing Chronic Care with Effective Scalable Solutions, or ACCESS, Model Financial Structure and Clinical Performance webinar. Thank you all so much for joining us today. Next slide, please. Before we get started, we will share some brief housekeeping remarks. During today's presentation, all participants will be in listen-only mode. We recommend that you listen via your computer speakers, but we also have the option to dial in from your phone. The dial-in information is available on the screen. Today's presentation is being recorded, and closed captioning will be available at the bottom of your screen. Additionally, at the end of the webinar, you will be directed to a brief survey to collect your feedback on the event. Next slide, please. Now we will review our agenda for today. First, we will begin with a welcome and introductions. We will use our time today to provide an overview of the model, review the model's eligibility criteria, outcome-aligned payment measures, and payment operational details. Then we will answer common questions you submitted in your registration forms and through the help desk. Please feel free to submit any questions you have in the Q&A box throughout the event. We also welcome you to email the ACCESS team at accessmodelteam@cms.hhs.gov. We will share this email address in the chat. This slide deck, along with a recording and a transcript of today's events, will be available on the ACCESS Model webpage in the coming weeks. I will now pass it over to Pooja Nair, ACCESS Model co-lead, to provide CMS remarks.
Everyone. As mentioned, my name is Pooja Nair, and I'm one of the co-leads for the ACCESS model. On behalf of CMS and the CMS Innovation Center, thank you for joining us today for this session. As part of the CMS Innovation Center, we develop and test new healthcare payment and service delivery models designed to improve patient care and affordability. We're excited to share this webinar on the ACCESS model, a nationwide 10-year voluntary innovation center model starting on July 5th, 2026. Thank you to those who tuned into the initial launch event last December. We've received really strong interest and engagement from you all, and we're looking forward to providing more information with you all today. The ACCESS model tests an innovative outcome-aligned payment approach in original Medicare to expand access to new technology-supported care options that help people improve their health and prevent and manage chronic disease. Historically, many patients with original Medicare have had limited access to technology-enabled care services for managing their chronic conditions because of Medicare payment barriers. ACCESS is designed to address these barriers by introducing an innovative payment option that focuses on measurable health outcomes rather than paying for activities. For context on the content behind today's presentation, we recently released a paper on the ACCESS model payment amounts and performance targets, which is posted on the model webpage. We'll review information from that document today, and we hope that this will be helpful as you prepare your application and familiarize yourself with the model. The payment amounts we'll discuss today reflect not only Medicare's direction, but the broader market's movement toward outcome-aligned payment. You may have seen our announcement a few weeks ago that major health payers covering Americans in Medicare Advantage, Medicaid, and commercial plans pledged to adopt outcomes-based payment similar to ACCESS. This multi-payer alignment signals that the payment approach that we've designed in ACCESS is increasingly becoming the standard across the healthcare ecosystem. As mentioned, please use the QA box at the bottom of your screen to submit any questions that you have. We'll have a QA session at the end of this webinar. Next slide, please. Now I'll introduce the rest of today's speakers. Next slide, please. Today, we're also joined by Nora Connor, who's my co-lead on the ACCESS model, as well as Brian Walderson, who's the director of the Division of Specialty Payment Models at the CMS Innovation Center. Next slide, please. Now we're going to share more information with you all about the ACCESS model. Next slide, please. Despite compelling evidence that technology-enabled care works, many people on original Medicare still cannot access these options due to a lack of viable payment through traditional Medicare. For clinicians who are interested in technology-enabled care for their patients, the current Medicare payment structures often limit what they can realistically offer. Through Access, CMS is testing a new outcome-aligned payment or OAP option that prioritizes results over activity volume. Access strives to give technology-enabled care organizations more flexibility to use innovative technology-supported delivery models that improve patient health and complement traditional care teams. There are four main goals of the Access model. First, Access empowers patients to achieve their health goals by improving access to new technology-supported care options. Original Medicare has historically lacked a payment pathway to adequately support novel technology-enabled care. Fee-for-service pays for a defined set of activities that don't align with the way technology-supported care is delivered, continuously, remotely, and often asynchronously, not just in the doctor's office. Second, Access promotes clinician-guided, accountable, and coordinated technology-enabled care by creating a straightforward payment pathway for organizations that currently lack viable reimbursement options in Original Medicare. By rewarding outcomes rather than volume of services delivered, Access gives these organizations greater flexibility to deliver continuous, integrated chronic care using modern technology. Third, Access drives choice and competition by promoting transparency of participant performance. CMS will maintain a public directory on Medicare.gov showing all Access participants, the tracks and conditions they treat, and their risk-adjusted outcomes. This transparency empowers patients and referring clinicians to make informed choices about which Access participant is the best fit for their needs. Finally, Access protects federal taxpayers by conditioning full payment on clinical outcomes. Participants earn the full payment amount only when patients meet measurable health goals, such as lowering blood pressure, reducing hemoglobin A1C, or achieving meaningful improvement in chronic pain or depression symptoms. This approach ensures Medicare pays for results that prevent costly complications. Each of these goals align with the CMS Innovation Center's mission to test innovative healthcare payment and service delivery models that have the potential to lower Medicare spending while maintaining and improving the quality of patient care. Next slide, please. Before we get into more detail on the Access model, we'll provide a quick overview of the clinical tracks for this model. The Access model addresses high prevalence, high cost chronic conditions affecting millions of Medicare beneficiaries through four initial clinical tracks that group clinically related, frequently comorbid conditions. The conditions in these tracks affect more than 2/3 of people with Medicare. Access participants are responsible for managing all qualifying conditions a beneficiary has within a track, supporting integrated patient-centered care. So let's walk through each track now. The Early Cardio-Kidney Metabolic, or ECKM track, targets early intervention to prevent disease progression. Qualifying conditions include either hypertension or two or more of the following: dyslipidemia, which is abnormal lipid levels, including high cholesterol, obesity or overweight with a marker of central obesity, and prediabetes. And the key here is early. We're focusing on prevention before conditions advance. The Cardio-Kidney Metabolic, or CKM track, addresses more advanced cardio-kidney metabolic conditions with higher clinical complexity, including diabetes, chronic kidney disease, and cardiovascular disease. The Musculoskeletal, or MSK track, includes chronic musculoskeletal pain. And finally, the Behavioral Health track includes depression and anxiety. As we move through today's webinar, we'll discuss how outcome-aligned payments work in each of these tracks, including the specific clinical outcome measures and performance targets that determine payment. Next slide, please. Access introduces a new payment approach that expands Medicare beneficiaries' access to technology-enabled chronic care management while maintaining accountability for outcomes and coordinated high-quality care delivery. The Access model payment framework has three core components. First, OAP measure targets specify the clinical outcomes participants must meet to receive full payment, with targets tailored to each beneficiary's baseline clinical status and designed to reflect meaningful improvement over time. Second, OAP performance thresholds set the minimum performance standards participants must meet to earn full payments, including requirements tied to the substitute spend and the clinical outcomes adjustments. Third, OAP amounts are the fixed annual payment rates that vary by clinical track and care period. A care period is defined as the 12-month period during which an Access participant is responsible for delivering care for the attributed conditions and achieving specified clinical outcomes. These OAPs are recurring monthly payments for managing a patient's qualifying condition where payment is tied to achieving measurable health outcomes. The goal here is to reward results, not individual activities, and to give clinicians flexibility to deliver technology-supported care that improves patients' health. Together, these features establish baseline adjusted outcomes for each individual patient, define performance thresholds, and determine outcome-based payments. Next slide, please. Now we'll go through the model timeline. Applications for the Access model opened on January 12th. In February, we released the payment amounts and performance targets paper, and as mentioned, this document is now available on the Access model webpage. In early March, we'll be releasing the implementation guide for your Access application programming interfaces or APIs on the CMS website. In mid-March, the Access team will host office hours on API implementation and data submission that'll cover information included in the implementation guide. And applications for the first cohort of the Access model will be due on April 1st. Applicants will be notified of selection decisions in late spring. The participation agreement deadline for the first cohort is June 1st, and following this, the first cohort will begin on July 5th. I'll now pass it over to my co-lead, Nora, who'll be speaking to the next section. Next slide, please.
Thank you, Pooja. Now we will discuss the Access model's participant eligibility criteria. Next slide, please. Organizations must meet the following criteria to participate in the Access model. First, they must be a Medicare Part B enrolled organization, identifiable by a single tax identification number or TIN that is eligible to bill under the Medicare Physician Fee Schedule or PFS. Second, organizations must be a legal entity formed under applicable state, federal, or tribal law and authorized to conduct business in each state in which they operate. They must designate and maintain a Medicare enrolled physician as the medical director. This individual will be responsible for oversight of care delivery and model performance of the organization. They must ensure that all physicians and non-physician providers that are providing care or supervising care are individually enrolled in Medicare. Providers must have reassigned their Medicare billing rights to the participating TIN, and they must practice in accordance with applicable licensure and scope of practice requirements. Finally, organizations must submit and maintain an up-to-date roster of these Medicare enrolled providers with national provider identifications or NPI numbers, who are basically the people that are furnishing care or supervising care underneath the organization's TIN. Next slide, please. As I mentioned, Access participation is at the organizational level, with each Access participant identified by a single organizational TIN, and all providers delivering care must also be individually enrolled in Medicare. We recognize that many participants in Access may not already be enrolled in Medicare, so we have some guidance. If you're interested in applying for Access and are not already enrolled in Medicare Part B, we have provided some of these steps to help you through the enrollment process. So I'll also note that applicants should start the Medicare enrollment process as early as possible because applications cannot be fully approved for participation until Medicare enrollment is complete. And as well, it can take some time to get through that process. So CMS is allowing a grace period for Medicare enrollment. Your organization must be Medicare enrolled by June 1st, 2026, which is the same date as the deadline for signing the participation agreement. So the first step is for providers and suppliers to apply for a National Provider Identification Number, or NPI. To apply, please visit the NPPES website, which will be shared in the chat. That's the National Plan and Provider Enumeration System. Step 2, once the provider or supplier has an NPI, prospective participants must complete the Medicare Part B enrollment application using the PACO system. That's the Provider Enrollment Chain and Ownership System. You should apply as the provider type that is most appropriate for your organization, and also making sure that that provider type is eligible for access. So note that access excludes durable medical equipment suppliers and lab suppliers from participation in the model. Based on the application type and the practice location, PICOS will then display the appropriate MAC, which is the Medicare Administrative Contractor. That's the person that you'll contact for additional resources on enrolling and enrollment status updates. We have several resources for selected MACs at the end of this presentation to share with you all, and you can find a link to the MAC contact list in the Zoom chat. If your TIN operates across multiple states, you will only be required to coordinate with one MAC in the state that corresponds to your administrative headquarters. And then finally, as a reminder, access participants must meet all standard Medicare participation requirements, such as accepting Medicare assignment. Next slide, please. Now we will discuss the access model's outcome-aligned payment measures. Next slide, please. As mentioned, care periods are 12-month periods during which access participants are accountable for outcomes. OAP measure targets apply per care period. So for each new care period, the target for each beneficiary is either minimum improvement or control. Minimum improvement reflects a minimum change that is clinically meaningful, but is not necessarily the beneficiary's ultimate goal. For instance, if an ECKM beneficiary begins their initial period with a systolic blood pressure of 160, they would have a minimum improvement target of 145 by the end of their 12-month care period. However, that is not their ultimate clinical goal, which is to have their blood pressure be below 130. It's important to note that OAP measure targets work in tandem with other model features to support care quality. So for example, CMS will publicly report each participant's risk-adjusted outcomes. For control is defined as the guideline-directed target in the access model that indicates remission or maintenance of the qualifying condition. So beneficiaries may achieve control during the care period or have a baseline measurement at or below the model-defined control threshold at alignment. The access participants' responsibility for these beneficiaries is achieving and maintaining control. This maintenance-focused approach is a feature of the access model that recognizes that preventing disease progression in patients who have achieved control represents meaningful clinical value and that it requires ongoing care delivery. Next slide, please. Continuing with our example of blood pressure, this example describes paths to success for the blood pressure improvement or control measure for patients with different baseline values. So for instance, for a patient with a baseline systolic blood pressure of 140, their goal is to achieve control, defined as systolic blood pressure below 130. If they're at 126, the path to success is maintenance of control below 130. If they start at 152, then the path to success is their minimum improvement goal, achieving less than 137. So for patients that are starting near the control threshold, like that 140 example that we gave, achieving their target may require lower than otherwise the minimum improvement target. Next slide, please. Payment in the access model is contingent on achieving track-specific clinical outcomes, or OAP measure targets, which are defined relative to each individual patient's starting point. The OAP measures for both the ECKM and CKM tracks are blood pressure, weight, hemoglobin A1C, and LDL-C. Again, minimum improvement for these targets reflects a minimum change that is clinically meaningful, not necessarily the beneficiary's ultimate clinical goal. The CKM track also contains 2 additional kidney health OAP measures, eGFR and UACR. These measures are essential markers for detection and staging of chronic kidney disease. Kidney health monitoring is only required for beneficiaries with a qualifying condition of diabetes or chronic kidney disease. This requirement supports appropriate monitoring of kidney function progression in high-risk populations. CMS has not set minimum improvement targets for this measure. Instead, this target is successfully met when these clinical data points are reported to CMS. Each of these measures has a clinical validity window, which is the maximum allowable time between when the OAP measure is collected and when it is submitted to CMS. For LDL-C, the clinical validity window is up to 1 year for beneficiaries with dyslipidemia and up to 2 years for all other beneficiaries. For hemoglobin A1C, the window is up to 1 year for beneficiaries with prediabetes or diabetes and up to 2 years for all other beneficiaries. For blood pressure, weight, and BMI, the clinical validity window is up to 15 days. Next slide, please. The MSK track measures are focused on improvement in physical function and pain interference, reduction of pain intensity, and improvement in patients' global impression of change. There are no control targets in this track because the MSK track is designed to incentivize minimum improvement rather than any kind of maintenance or control of existing symptoms. For the MSK measure, there are this is the musculoskeletal pain measure. For the OAP measure, that is musculoskeletal pain, improvement in physical function, and pain interference, there are 6 different patient-reported outcome measures, or PROMs, that participants can choose from depending on where the patient experiences pain. Each of these measures has its own minimum improvement requirements, which are listed here. The PROMIS instruments may be used for all sites of pain. Pain intensity, the OAP measure for pain intensity, requires a minimum improvement measured by the Numeric Rating Scale, or NRS. And Patient Global Impression of Change, or PGIC, does not have a minimum improvement threshold. However, access participants are required to report this outcome at the end of the period. Next slide, please. The behavioral health track measures include depression, anxiety, global impression of change, and overall function, which is optional. So control and minimum improvement measures for depression and anxiety are measured by the Patient Health Questionnaire 9, or PHQ-9, and the General Anxiety Disorder 7, or GAD-7. As in the MSK track, the Patient Global Impression of Change, PGIC, is required for reporting only. There is no minimum improvement target. Overall function is an optional measure using the World Health Organization Disability Assessment Schedule 2.0, which is also known as WHODAS 2.0. The clinical validity window is up to 15 days for all of the OAP measures in both the behavioral health and MSK tracks. So as a reminder, all of this information that we've just reviewed is included in the model payment amounts and performance targets paper, which is linked in the chat. And these slides will be available on the CMS website in the coming weeks. Next slide, please. So as I mentioned earlier, certain OAP measures only require data submission or reporting, and they do not require achievement of minimum improvement or control. These measures support calibration of measure targets and fulfill monitoring requirements essential to comprehensive chronic disease management. First of all, kidney health monitoring is required for the CKM track patients with diabetes and chronic kidney disease at the start of each care period. Success for the CKM track requires submitting eGFR and UACR results on time and at the start of each care period. These measures have a clinical validity window of up to 1 year. The Patient Global Impression of Change is required for all patients in the behavioral health and MSK tracks. It is a one-question instrument that will help CMS set meaningful improvement targets for patient-reported outcome measures, such as the PHQ-9, GAD-7, and MSK OAP measures. Success criteria include response data for the one-question PGIC assessment at the end of the period. Since this is a patient-reported outcome measure, it has a clinical validity window of up to 15 days. I will now pass it back to Pooja to cover payment operational details. Next slide, please.
Sure. Now we'll move on to payment operational details. Next slide, please. The access model establishes annual allowed amounts for initial periods and follow-on periods of care for each of the 4 clinical tracks. OAPs are calibrated to reflect expected resource needs for participants to provide technology-enabled care while remaining below comparable fee-for-service costs to incentivize efficiency. This table displays the annual payment allowed amounts by track for the effective period. As shown in the table, payment rates vary by track and by care period type. The initial period payment amounts reflect the higher resource needs associated with onboarding, establishing care relationships, and achieving clinical improvement. It corresponds to the first time a participant is treating a patient in the clinical track within the past 2 years and requires that at least one of the patient's OAP measures is not a target. For beneficiaries in the ECKM and CKM tracks who reside in rural areas, CMS will include an additional fixed payment of $15 during the initial period to offset higher operational costs. For example, for distributing a cellular network connected blood pressure cuff. The follow-on period payment amounts reflect lower resource needs for continued management or maintenance of care. A beneficiary qualifies for follow-on period payment when a participant is continuing to manage them for the same track within the past 2 years, or when initiating care for a beneficiary whose OAP measures are all at target at baseline. Note that the MSK track does not include a follow-on period. This track is designed for a single 12-month episode focused on reducing or resolving chronic pain, reflecting the episodic nature of musculoskeletal treatment. Allowed amounts represent the maximum annual payment per beneficiary for each track and include both the Medicare program payment, which covers 80%, and a beneficiary coinsurance, which covers the remaining 20%. Access participants may adopt a uniform policy to forego collection of beneficiary coinsurance as a beneficiary incentive. Allowed amounts do not reflect potential downward payment adjustments resulting from the clinical outcome adjustment or substitute spend adjustment applied to the Medicare paid amount. We'll go into more detail about clinical outcome and substitute spend adjustments shortly. CMS will issue billing instructions to participants, including the specific G codes in advance of model launch. Next slide, please. So now let me walk you through how the payment mechanics work in practice. Regarding monthly billing and payment, access participants must submit valid claims using track-specific G codes for processing by their MAC, just like standard Medicare Part B claims. CMS will then issue monthly payments equal to 1/12 of the Medicare portion of the annual OAP allowed amount. Regarding the payment withhold structure, CMS will pay those monthly payments in months 1 through 6, representing up to 50% of the Medicare portion of the annual OAP allowed amount. Payment for claims submitted in months 7 through 12 will be withheld for reconciliation. The withheld payments will then be reconciled after the 12-month care period ends. If the participant meets the minimum performance threshold for the entire panel of patients, for example, 50% of patients meeting all outcome targets in year 1, the withheld payments would be released, and in other words, the participant earned 100% of the payments. In the case that a beneficiary is in multiple clinical tracks with the same access participant, CMS applies a 5% discount to the monthly OAP of the lower cost track or tracks. This is meant to reflect administrative and operational efficiencies associated with delivering integrated care. If the overlap occurs in the first 6 months of the lower cost track, CMS applies the 5% discount to the monthly OAP payments. If the overlap occurs in the last 6 months of a beneficiary's alignment, CMS applies the 5% discount through the reconciled OAP. The multi-track discount is not applied to the beneficiary's coinsurance responsibility for access services. If a beneficiary is aligned to different clinical tracks with different access participants, no multi-track discount applies, and each access participant receives the full Medicare portion of the allowed amount for their respective tracks. Next slide, please. Here's an example showing the multi-track discount in action. As mentioned previously, when a beneficiary is enrolled in multiple tracks with the same access participant, CMS applies a 5% payment discount to the monthly OAP amount of the lower cost tracks. In this example, let's say a beneficiary starts in the ECCAM track for the initial period, months 1 through 12, with a Medicare annual payment amount of $24 per month or $288 for the year. This is the maximum OAP amount. In month 7, the beneficiary also enrolls in the MSK track with the same access participant with a Medicare annual payment amount of $12 per month or $144 annually. At reconciliation, CMS applies the 5% multi-track discount to the lower cost MSK track for the overlap in months 7 through 12, which results in a $3.60 adjustment or 60 cents per month. If a beneficiary is aligned to 3 tracks with the same access participants during any overlapping months, CMS will apply the discount to the 2 lowest cost tracks. I'll now pass it over to Brian, who will be going over the rest of this section. Next slide, please.
Thank you, Pooja, and hello, everyone. Moving on to the payment adjustments. Access uses an outcome-adjusted payment methodology that links payment to achieving measurable clinical and patient-reported outcomes. Payment amounts are subject to 2 potential downward adjustments. First, a substitute spend adjustment or a clinical outcome adjustment. CMS will only ever apply one of these 2 adjustments. Whichever percentage is greater will be applied to the Medicare portion of the outcome adjusted payment. So first, for the substitute spend adjustment, this reduces payments when aligned beneficiaries receive duplicative substitute services from other Medicare providers above a defined substitute spend threshold. And each clinical track includes a substitute spend list, which identifies services considered potential substitutes for care provided by participants for any condition in the clinical track. And then second, the clinical outcome adjustment is based on the access participant success rate, otherwise known as the outcome attainment rate, or OAR. And the OAR is compared to a defined performance threshold for success, the outcome attainment threshold, or OAT. Next slide, please. Okay, so let's start with the substitute spend adjustment. This adjustment focuses on reducing duplicative Medicare spending and encouraging comprehensive care delivery by the access participant. So each clinical track includes a substitute spend list, identifying services considered substitutes if provided by another Medicare entity for any condition in the clinical track. And we will list out these services in the next few slides. Substitute services are specific Medicare physician fee schedule services that, if provided to an access-aligned beneficiary during an active care period, are considered duplicative of or substitutes for services expected to be provided by the access participant. So the adjustment itself is determined by the equation shown here. And the substitute spend threshold will be set at 90% for all participants between July 5th, 2026 and December 31st, 2027. This whole threshold represents the minimum substitute spend rate needed to earn a full payment. The percentage of access beneficiaries who do not receive substitute services is compared to the substitute spend threshold. If the substitute spend rate is above 90%, is below 90%, then the participant will receive a proportional payment calculated by dividing the substitute spend rate by the substitute spend threshold and multiplying by the total annual OAP amount. The maximum adjustment for this reduction is capped at 25% of the OAP. And then an important point here is that care provided by non-access entities for services on the substitute spend list will continue to be reimbursed under standard Medicare payment rules. So beneficiaries will not experience any problems with accessing existing Medicare services. Next slide, please. Okay, so to be included in the substitute spend adjustment calculation, the following services covered over the next few slides must be furnished by another Medicare enrolled provider or supplier during the beneficiary's access care period. And the principal diagnosis code on the claim must match any qualifying condition in the beneficiary's access track. These initial lists of included services for the CKM and ECKM track, and then behavioral health and MSK track services will be on the next slide, are generally focuses on the initiation of new care for the same diagnosis. So this slide here shows the track service type and the corresponding CPT or HCPCS code associated with that service. And the information on this slide can also be found in Appendix E of the RFA, which was just shared in the chat. Okay, and next slide, please. And then as promised, this slide shows included substitute spend services for the MSK and the behavioral health tracks. One thing to note is that the behavioral health track service type table listed has recently been updated in the latest version of the RFA. So go ahead and take a look at that in Appendix E. Next slide, please. Okay, so moving on to the second potential adjustment. To determine the clinical outcome adjustment, we calculate the outcome attainment rate, or OAR, and compare it to a defined performance threshold for success, the outcome attainment threshold. So the OAR is calculated by dividing the number of beneficiaries who have achieved all measure targets and submission requirements, which here is denoted the number of successful episodes, by the total number of beneficiaries aligned to the participants track for the applicable time period, which is also the total number of episodes. For an aligned beneficiary to be counted towards a participant's OAR, all of their required OAP measures for the applicable track must be reported on time and their targets must be met. Partial target attainment will not constitute success for this measure. Then the optional HUDAS 2.0 measure does not affect outcome attainment and may be reported at the participant's discretion, though we note that this measure may inform public reporting of outcomes and future measure refinement, so we strongly recommend reporting it. Beneficiaries who relocate outside of an access participant's licensed service area and beneficiaries who become ineligible during the care period are excluded from the numerator and denominator of the OAR calculation. And beneficiaries who initiate unalignment or who are lost to follow-up will remain in the denominator for inclusion in the OAR calculation. Okay, next slide, please. All right, so an access participant's outcome attainment threshold, or OAT, represents the minimum percentage of their aligned beneficiaries who must complete their care period and meet all required OAP measure targets to earn full payment. The OAT is set at 50% for all access participants from July 2026 through the end of 2027. And the OAT was set at 50% to allow access participants to earn full payment based on strong overall performance, even if some beneficiaries do not meet all targets. So it allows for some outliers there. The 50% OAT is also intended to provide access participants with flexibility to achieve success despite some level of beneficiary disengagement. So CMS calculates the clinical outcome adjustment by comparing the access participant success rate, the OAR, to the OAT, which is the minimum OAR that access participants must achieve to receive the full withheld amount. If the OAR is greater than or equal to 50%, then the participant receives 100% of the withheld amount for all eligible OAP amounts for the assessed patient panel. So in other words, an organization can potentially earn 100% of the Medicare portion of the allowed amount for their aligned beneficiaries if at least 50% of their beneficiaries meet the required OAP measure targets. If a participant's OAR is below 50%, the participant will receive a proportional payment calculated as the OAR divided by the OAT multiplied by the full Medicare portion of the OAP allowed amount. As part of the model's monitoring efforts, we note that access participants that consistently fall short of the minimum threshold may be subject to termination. Okay, next slide, please. And Pooja, I'll hand it over to you.
Okay, so sorry about that. Zoom froze over here. Now we'll start on the Q&A portion of today's webinar. Next slide, please. Thank you all so much for your engagement throughout this presentation in the Q&A box. We'll now answer some questions, starting with those submitted from your registration forms. I'll run through each question and pass it to Nora to share our answer. Our first question is, how will the control group be defined, selected? Does that mean that not all original Medicare beneficiaries can participate in access?
So the control group will be randomly assigned during the eligibility check or align process. What will happen is 10% of Medicare beneficiaries who are attempting to align or check their eligibility for access will be randomly assigned to the control group. Those beneficiaries, once they're in the control group, will be ineligible to participate in the model for the next 12 months. However, they'll maintain all of their normal access to other Medicare services. Access participants are required to notify beneficiaries in advance of the possibility of being placed in the control group, and CMS will be providing additional guidance around that notification process in the participation agreement, which will be shared in the coming months.
Thanks, Nora. Our next question is whether access is available to FQHCs, or federally qualified health centers.
So CMS is working to enable FQHCs, or federally qualified health centers, to engage with access as referring providers. So that would mean they would be eligible for the co-management payments and would work directly with access participants and provide an additional location, additional resource for Medicare beneficiaries to receive digitally enabled and tech-enabled care. We'll have additional guidance forthcoming. This is something that CMS is actively working through.
Wonderful, thank you. Our next question is, are specialty care providers like physical therapists eligible to co-manage beneficiaries?
Yes. This is a recent change, which we're excited to announce. Physical therapists, occupational therapists, social workers, nurse practitioners, and physician assistants are all eligible to bill and receive payment for the co-management payments when they are coordinating care with an access participant on behalf of access beneficiaries.
Thanks, Nora. Our next question is, what does it take to succeed as an access participant?
Great question. Successful access participants will be those that measurably improve patient health and reduce care costs in a scalable, cost-effective way. We anticipate this will require a couple things. Number one is going to be continuous patient engagement. So actively monitoring progress and intervening early throughout the 12-month care period will be really important to maintain patient engagement and to make sure that patients are following through with recommended interventions. Second, care coordination is going to be key. So partnering with patients' existing providers, including their primary care provider or any of those referring clinicians like physical therapists that we just mentioned. Leveraging those trusted relationships will more likely lead to improved outcomes. And the third thing that's going to be really essential here, obviously, is technology-enabled delivery. So using digital tools to deliver care efficiently and at scale. Just as a reminder, the access model is designed to provide flexibility in how care is delivered, allowing participants to innovate within established guardrails. But ultimately, organizations that combine strong clinical outcomes with operational efficiencies will be the best positioned to succeed in access.
Our next question is related to participation, the application process in particular. Will all eligible applicants be approved for participation, or is this a competitive application process?
Not all applicants will be accepted into the access model. CMS will be reviewing all eligible applications for completeness and compliance with model eligibility criteria. As we stated in the RFA, the request for applications, CMS may deny participation based on concerns around program integrity, including adverse legal history, failure to meet the enrollment requirements, or other risks around compliance. To review the steps for becoming an access participant, an organization must submit a complete application via the participant portal. They must be approved for participation by CMS, and then they must sign the participation agreement and all other required documentation by the CMS deadline. So just to review, just submitting an application does not guarantee participation in the access model. Organizations that have submitted an application but are not yet approved or that have not signed the participation agreement are not access participants and have no obligation to participate. So if an applicant wishes to formally withdraw their application before signing the participation agreement, they may do so by submitting a written withdrawal request to Access Model Team at cms.hhs.gov on organizational letterhead signed by an authorized corporate official.
Nora. So whereas the first set of questions related to participant eligibility, this next set pertains to payment. Our first question in this set relates to model or program overlap. How will access payments overlap with other value-based care models?
The access model offers an outcome-aligned payment option that replaces traditional fee-for-service billing. So participants in access may not submit Medicare fee-for-service claims for their aligned beneficiaries during those patients' active care periods. The fee-for-service exclusion in access applies at the beneficiary level for a given access participant. So what this means is that an organization can participate in access and align some patients to the access model while continuing to align other patients to their traditional fee-for-service billing or other payment arrangements for those separate set of patients. So as long as those sets of patients are kept separate, Organizations may continue to participate in other value-based care models as well as participating in access. In addition, just as a reminder, organizations that are not access participants at the TIN level will see no impact on their normal fee-for-service billing operations. They can continue to participate in value-based care as normal.
Thank you. Our second question has to do with the payment amounts that we recently released and also discussed today. Nora, could you explain how the rates were determined for each model track?
Certainly. So outcome-aligned payments are recurring payments for managing a patient's qualifying conditions with payment tied to achieving measurable health outcomes. This approach, as we know, rewards results, not activities, and it enables flexible and technology-supported care. The rates themselves were calibrated to reflect the expected resource needs for participants to deliver effective, integrated, technology-enabled care within each clinical track. These rates are likely to be most attractive to organizations that are seeking to deliver scalable and effective technology-enabled care, which we should note has traditionally lacked a viable payment option within original Medicare. A couple other notes. The model's public outcome reporting is meant to ensure that care delivery models access participants that meaningfully improve health are the ones that will ultimately scale and thrive within the access model. And finally, just as another point here, CMS is also investing in broad awareness building efforts, including marketing campaigns, outreach to beneficiaries, and meeting with referring clinicians and provider groups to drive engagement with access participants, including driving awareness around co-management payments and other avenues to engage with access participants.
Thank you, Nora. Our third and last set of pre-prepared questions relates to Access's quality metrics and also data reporting. This first question in the set is related to rationale for these metrics that we've selected. How is CMS thinking about metrics to evaluate outcomes?
Very carefully. Each of our 4 clinical tracks includes a set of guideline-informed and condition-specific measures and outcome targets. CMS determines payment based on the overall share of patients who meet their defined outcomes compared to a minimum threshold that CMS has initially set at 50% for all participants. The idea is that this is going to balance accountability with accessibility and reward strong performance. I think it's worth mentioning too that there's we're anticipating that access participants may have difficulty keeping all of their patients engaged for a full 12 months, and that's why we've set the threshold at 50%.
Nora. So finally, and a quite timely question, we received questions related to data reporting as this will be a really important operational piece to participants. The question is, when will the CMS API design details become available?
So CMS is developing an API implementation guide for Access. The Access implementation guide contains detailed information on API requirements and designs, and it will be available on the Access Model webpage in the coming weeks. In addition, we are hosting a data submission and API implementation office hour in mid-March that will provide further information on the Access APIs. So for folks who are interested, whether they're developers, whether there are folks who would like to just learn more about sort of the requirements for data submission, information about that will be coming very soon.
Thanks, Nora. That concludes all of the questions that we received prior to this webinar that we had the opportunity to prepare responses for. I think at this point we could potentially answer a couple questions that came directly from participants attending this webinar. Great, so we have one. And this question also kind of pertains to this last set of questions discussed regarding quality or performance. The question is, where can we find the clinical validity windows for CKM and ECKM tracks?
That's a great question. So the clinical validity windows for those tracks are listed in the model payment amounts and performance targets paper. Those are listed, that paper is posted on the Access website underneath the tab that's labeled additional information. We'll also include a link to that in this chat.
Thanks, Nora. And we have, I think, room for just one more. We see another question. Can an organization participate in more than one track?
Yes, absolutely. An organization can participate in all 4 tracks, or just one. That's at the discretion of the organization. Also worth noting that individual CMS beneficiaries can qualify for more than one track at a time, and they can receive those services from the same access participant or different access participants. So it's certainly an option for access participants to participate in up to all 4 tracks, and have participants in multiple tracks at a time, with the exception of ECKM and CKM tracks, because those are on sort of a disease progression continuum. So a patient would only ever be in ECKM or CKM at the same time.
Thank you so much for that, Nora, and thank you to everyone for your attention and engagement during today's session. That is all of the Q&A that we can cover today. We really appreciate all of the thoughtful questions that you've shared in the chat. Additional information will be available later. And for any further questions, please feel free to email our team at accessmodelteam@cms.hhs.gov. That's accessmodelteam@cms.hhs.gov. Also dropped in the chat. Next slide, please.
All right, we will now go over some brief closing remarks and resources. Next slide, please. Thank you all for joining today's webinar. We have a few exciting upcoming events and information releases for Access in the coming months. First of all, please join us for the API implementation and data submission technical office hour. It's happening later this month. We're going to review the implementation guide information, required data submissions, and the access. We'll be sharing that office hour invitation in a day or two. So look out for that coming very soon. We will also be releasing an additional paper that lays out the scoring methodology, denominator exclusions, so clinical exclusions from the access model, billing guidelines, and other key operational details. So also keep your eyes open for that. Next slide, please. To learn more about the Access model, please visit the Access website, which is listed in the chat and will be linked from these slides. The website has important information and resources such as the upcoming implementation guide will be posted soon, our payment amounts and performance target that we've referenced several times. We also have the request for applications document available on the website. As a reminder, these slides, transcript, and recording will be available on the model webpage in the coming weeks. If there are any outstanding questions, we welcome everyone to email them to the model team via the help desk email. That's the one at the very top here. We'll be using the questions received during this event and via email to inform updates to the model's frequently asked questions website. So also keep checking that FAQ site because we do update questions pretty frequently. Next slide, please. Thank you so much for your time and interest. Please take a couple minutes to fill out the post-event survey. Your browser should direct you to the form after this event. As always, we look forward to continuing to connect with you. Very excited about this model. And with that, this concludes today's event. Thank you so much for joining us, and we hope that the information was helpful.